Hello, my name is Donna Edwards and welcome to Addiction Counselor CEU. We are going to be discussing anxiety disorder. Anxiety. What distinguishes fear from anxiety? Fear is a state of immediate alarm in response to a serious known threat to one's well-being. Anxiety is a state of alarm in response to a vague sense of threat or danger. Is the fear-anxiety response useful, adaptive? Yes, when the flight or fight response is protective. However, when it is triggered by inappropriate situations or when it is severe or long-lasting, this response can be disabling. It can lead to the development of anxiety disorder. Generalized anxiety disorder. State of persistent and excessive anxiety and worry about numerous events and activities, difficulties in concentration, signs of muscle tension, sleep problems. Sometimes described as free-floating anxiety. Typically feels restless, keyed up, or on edge. Symptoms last at least 6 months. Theory holds that GAD is caused by biological factors, supported by family pedigree studies. How many relatives have had the same disorder? Blood relatives more likely to have GAD, 15%, than general populations, which were 6%. The closer the relative, the greater the likelihood. Issue of shared environment. In the normal fear reaction, key neurons fire more rapidly, creating a general state of excitability experienced as fear or anxiety. A feedback system is triggered. Brain and body activities work to reduce excitability. Some neurons release GABA, gamma-aminobutyric acid, to inhibit neuron firing, thereby reducing experience of fear or anxiety. More on the biological perspective. Problems with the feedback system are believed to cause GAD. Possible reasons: the GABA is too low, too few receptors, ineffective receptors. The biological treatments: the anti-anxiety drug therapy, antipsychotics and antidepressants increasingly popular, the benzodiazepines, which is Valium, Xanax, found to reduce anxiety, risk of dependency, and the undesirable side effects such as memory loss, depression, and drowsiness, dangerous if mixed with other drugs or substances. Here is the GAD social culture perspective. The theory of GAD is most likely to develop in people faced with social conditions that truly are dangerous. Research supports this theory. One of the most powerful forms of societal stress is poverty. Why? Rundown communities, higher crime rates, fewer educational and job opportunities, and greater risk for health problems. As would be predicted by the model, there are higher rates of GAD in lower SES groups. Although poverty and other social pressures may create climates for GAD, other factors are clearly at work. How do we know this? Most people living in dangerous environments do not develop GAD. GAD from the psychodynamic perspective. The theory is that childhood anxiety goes unresolved. Early developmental experiences, such as a child is severely punished when they do something wrong, or inadequacies in early parent-child relationship. The psychodynamic therapies. Overall controlled research has not consistently shown that the psychodynamic approaches are helpful to treating cases of GAD. Short-term dynamic therapy may be beneficial in some cases. The theory with GAD is caused by maladaptive assumptions. Albert Ellis identified basic irrational assumptions. It is the catastrophic when things are not as one wants them to be. If something is fearful, a person should be terribly concerned and dwell on the possibility that it will occur. When these assumptions are applied to everyday life, GAD may develop. Beck, the cognitive theorist. Those with GAD hold unrealistic silent assumptions that apply imminent danger. Any strange situation is dangerous. A situation or person is unsafe until proven safe. Research supports the presence of these types of assumptions in GAD, particularly about the dangerousness. What kinds of people are likely to have exaggerated expectations of danger? Those whose lives have been filled with unpredictable negative effects. To avoid being blindsided, they try to predict events. They look everywhere for danger and therefore see danger everywhere. Theory still under investigation. Second-generation cognitive explanations. In recent years, two promising explanations have emerged. Metacognitive theory. It holds that the most problematic assumptions in GAD are the individual's belief about worrying itself. The avoidance theory, which holds that worrying serves a positive function for those with GAD by reducing unusual high levels of bodily arousal. Both theories have received considerable research support. Cognitive therapy, changing the maladaptive assumption based on the work of Ellis and Beck, helping clients understand the special role of worrying plays, the changing their lives, their views about all. We have some fears at some point in our lives. This is a normal and common experience. How do phobias differ from these normal experiences? More intense fear, greater desire to avoid the feared object or situation, distress that interferes with functioning. Social phobias are severe, persistent, and unreasonable fears of social or performance situations in which embarrassment may occur. May be narrow, talking, performing, eating, or writing in public. may be broad, general fear of functioning inadequacy in front of others. In both cases, people rate themselves as performing less adequately than they actually did. What causes phobias? Evidence tends to support the behavioral explanations. Phobias developed through conditioning. Once fears are acquired, they are continued because feared objects are avoided. Phobias develop through modeling, observation, and imitation. Phobias are maintained through avoidance and safety behaviors. A behavioral evolutionary explanation. Theorists argue that there is a species-specific biological predisposition to develop certain fears, called preparedness. Humans are more prepared to develop phobias around certain objects or situations. Model explains why some phobias, such as snakes or heights, are more common than others, like grass or meat. How are phobias treated? Surveys reveal that 19% of those with specific phobia and 25% of those with social phobia currently are in treatment. Behavioral techniques, exposure treatments, are most widely used, especially for specific phobias, shown to be highly effective, far better in head-to-head comparisons than other approaches, include desensitization, flooding, or modeling. Treatments for specific phobias. Systematic desensitization. Teach relaxing skills. Create fear hierarchy. Sufferers learn to relax while facing feared objects. Since relaxation is incompatible with fear, the relaxation response is thought to substitute for the fear response. Several types are in vivo desensitization live and convert desensitization imaginal. Other behavioral treatments: flooding, forced on gradual exposure, modeling. Therapist confronts the feared object while the fearful person observes. Clinical research supports each of these treatments. The key to success is actual contact with the feared object or situation. Treatments for social phobias. Two components must be addressed: overwhelming social fear, addressed behaviorally with exposure, lack of social skills. Social skills and assertiveness trainings have proved helpful. Unlike specific phobias, social phobias respond well to medication, particularly antidepressive drugs. Several types of psychotherapy have proved at least as effective as medication. People treated with psychotherapy are less likely to relapse than people treated with drugs alone. One psychological approach is exposure therapy, either in an individual or group setting. Another treatment option is social skills training. Panic disorder. Panic, an extreme anxiety reaction, can result when a real threat suddenly emerges. The experience of panic attacks, however, is different. Panic attacks are periodic, short bouts of panic that occur suddenly, reach a peak, and pass. Sufferers often fear they will die, go crazy, or lose control. Attacks happen in the absence of a real threat. Anyone can experience a panic attack, but some people have panic attacks repeatedly, unexpectedly, and without apparent reason. The diagnosis is panic disorder. Sufferers also experience dysfunctional changes in thinking and behavior as a result of the attacks. An example is a sufferer worries persistently about having an attack, plans behavior around the possibility of future attack. What biological factors contribute to panic disorder? The neurotransmitter at work is the norepinephrine, irregular in people with panic attacks. Researchers suggest that panic reactions are related to changes in the norepinephrine activity in the locus coeruleus. The drug therapies include antidepressants, which are effective at preventing or reducing panic attacks. It brings at least some improvements to 80% of patients with panic disorder. 50% recover markedly or fully. It requires maintenance of drug therapy, otherwise relapse rates are high. Some benzodiazepines, especially Xanax, olanzapine, have also proved helpful. Combination treatments, medication plus behavioral exposure therapy may be more effective than either treatment alone. Panic disorder, the cognitive perspective, misinterpreting bodily sensations. Panic-prone people may be overly sensitive to certain bodily sensations and may misinterpret them as signs of medical catastrophe. This leads to panic. Why might some people be prone to such misinterpretations? Experience more frequent or intense bodily sensations, poor coping skills, lack of social support, unpredictable childhoods, and overly protective parents. Cognitive therapy may also be used as a biological challenge and produces to induce panic situations, induce physical sensations which cause feelings of panic. Cognitive therapy is often helpful in panic disorder. 85% of treated patients are panic-free for 2 years compared with 13% of controlled subjects, at least as helpful as antidepressants. Combination therapy may be most effective, still under investigation. Obsessive-compulsive disorder, made up of two components: the obsession, the persistent thoughts, ideas, impulses, or images that seem to invade the person's consciousness. The compulsions are repeated and rigid behaviors or mental acts that people feel they must perform to prevent or reduce anxiety. Features of obsessive and compulsions. Obsessions, it feels both intrusive and foreign to person experiencing them, can take the form of obsessive, wishes, X, repeated wishes that someone would die. The impulses, X, repeated urges to yell out obscenities. Images, X, fleeting visions or forbidden sexual scenes. And the ideas, X, is the notion that germs are everywhere. And the doubts are the concerns that one will make the wrong decision. The features of obsessive and compulsions. The compulsions are voluntary behaviors or mental acts. An example is cleaning, checking, touching, verbal, or counting. The feel is mandatory and unstoppable. Person may recognize that behaviors are irrational, believe that a catastrophe will occur if they don't perform compulsive acts. Performing behaviors reduces anxiety only for a short time. Behaviors often develop into rituals. OCD, the behavioral perspective, learning by chance. People happen upon compulsive randomly. In a fearful situation, they happen to perform a particular act, such as washing hands. When the threat lifts, they associate the improvement with the random act. Behavioral therapy. Exposure and response prevention. Clients are repeatedly exposed to anxiety, provoking stimuli, and prevent it from responding with compulsions. Therapists often model the behavior while the client watches. Homework is an important component. Treatment is offered in individual and group settings. Treatment provides significant, long-lasting improvements for most patients. OCD, the cognitive perspective, overreacting to unwanted thoughts. To avoid such negative outcomes, they attempt to neutralize their thoughts with actions or other thoughts. Neutralizing thoughts actions may include seeking reassurance, thinking good thoughts, washing, checking, and the cognitive therapy. Educate clients, point out how misinterpretations of unwanted thoughts, excessive sense of responsibility, and neutralizing acts maintain symptoms. Therapists guide clients to identify the challenge and change their distorted cognition. The OCD, the behavioral perspective. The role of the NT-serotonin, low serotonin activity. Evidence that serotonin-based antidepressants reduce OCD symptoms. The brain abnormalities. OCD linked to orbit region of frontal cortex and caudate nuclei. Either area may be too active, letting through troublesome thoughts